A very good morning to you. I am Dr. Navneet Nath, Prof and Head of Department of Pathology. Today we will be discussing Hodgkins disease. The recent WHO classification is based on an immunophenotype of the lymphoid cells and has placed Hodgkin's lymphoma in the category of mature B-cell neoplasias. It is discussed as a separate entity due to a distinct diagnostic and distinctive morphological feature, that is the presence of Reed-Steinberg cell. It arises in the lymph node, involves the extra-nodular sites secondarily, and comprises of 30% of the lymphoid neoplasias. This is a race classification which was brought about in the year 1966. This divides it further into a lymphocyte predominant type, or nodular sclerosis type, mixed cellularity type, and a lymphocyte depletion type. In the year 2022, WHO came up with a classification which further differentiated it based on the presence of RS, that is Reed-Steinberg marker cells, and reactive immune cells. So they classified it into prominently into two categories. One is the classical Hodgkin's lymphoma and the other one is the nodular lymphocyte predominant. Under the classical Hodgkin's lymphoma, which comprises of 98% of the Hodgkin lymphomas, it was further divided into nodular sclerosis, mixed cellularity, lymphocyte rich, lymphocyte depleted, and the second classification is nodular lymphocyte predominant. Now, what is an RS cell? A classic RS cell is defined as a large cell which can be up to 100 micromillimeter. It has a mirror image like picture. That means there are two nucleus which reflect each other like a mirror would reflect your image. There is an owl-like appearance. When I say owl-like appearance, that means each of the two nucleus has a prominent eosinophilic nucleolus with a hammer, and there is abundant eosinophilic cytoplasm. So this is how we will define a typical or a classical RS cells. We have the other type of RS cells also which do not fall in the category of classical RS cells, like lacunar type RS cells, polypoid type or popcorn RS cells, pleomorphic RS cells, and mummified RS cells. RS cells, the numbers are inversely proportional to the number of lymphocytes in Hodgkin's lymphomas. That means if there are more lymphocytes, you will have less RS cells. If there are less lymphocytes, you will have more RS cells. So it's inversely proportional. And IHC is the gold standard for the diagnosis of Hodgkin's disease. What does one get to see on gross examination? That means when you examine an patient, an individual, you will see that there will be cervical, supraclavicular and axillary group of lymph nodes which are more than often involved. These lymph nodes can be discrete, they can be matted, or they can be diffuse. So the presentation can be any of these three. If you take out the lymph node and you cut it, that is the biopsy of the lymph node is done and it is cut, it looks like a grey, white to fish-like appearance, the cut surface. Under the microscope, in a classical Hodgkin's lymphoma or Hodgkin's disease, we go on to the nodular sclerosis, which is the subtype of classical. Most frequently, it's a younger patient. The females show more bands of collagen. Females are more often affected. Bands of collagen are seen more in the lacunar RS cells. The characteristic halo is due to the shrinkage of the cytoplasm. Fibrous septae are infiltrated by histiocytes, lymphocytes, macrophages, and necrosis. Going on to the next type, which is the mixed cellularity Hodgkin's lymphoma. The age generally is 50 years. The entire lymph node is replaced by lymphocytes, histiocytes, eosinophils, neutrophils, plasma cells, and typical RS cells. Lymphocyte-rich Hodgkin's lymphoma will show you a diffuse pattern, proliferation of small lymphocytes and histiocytes. No other cells will be seen. No other cells of the reactive immune type will be seen. RS cells is a must for a diagnosis. But as you know, if there are more lymphocytes, you will find relatively less RS cells. So you will have to hunt for the RS cells. You will have to look specifically for the Reed-Steinberg cell. Coming to the fourth subclassification of classical lymphomas, lymphocyte depleted Hodgkins lymphoma. This will show you a diffuse fibrotic variant. The cells are decreased in number. The entire lymph node may be fibrotic. Atypical and typical RS cells may be seen or will be seen. An RS cell has to be seen, whether it is atypical or typical. Then you have the reticular variant, which also is a part of the lymphocyte depleted Hodgkin's lymphoma. So this is more cellular, a large number of pleomorphic atypical Reed-Steinberg cells and scant lymphocytes are seen. Nodular lymphocyte predominant. That's another subtype of the classical lymphoma. You see a predominance of lymphocytes, sparse number of RS cells as mentioned earlier. They are inversely proportional to the number of lymphocytes. So if you are seeing a large number of lymphocytes, you see a relatively less number of RS cells. It has a nodular growth pattern. It grows in the form of nodules. The different types of RS cells that one can get to see in this category are typical RS cells, polypoidal RS cells, popcorn or twisted RS cells. Twisted is the nucleus is twisted, so it gives a popcorn-like appearance. RS cells have a distinctive immunophenotyping. That means it's positive for CD45, EMA, and the usual markers like CD15 and CD30 are also positive. So we have 4 markers that we can run on the RS cells: CD45, EMA, CD15 and CD30. It tends to have a relapsing course. Some cases may transfer into the large B-cell non-Hodgkin's lymphoma. So means we can jump from the Hodgkin's to the non-Hodgkin's. The other laboratory findings in Hodgkin's lymphoma are hematological findings like anemia, decreased serum iron and TIBC with normal iron stores, bone marrow failure, the leukoerythroplastic reaction, leukemoid reaction or absolute leukopenia, normal or increased platelet count, increased ESR. The immunological findings one will get to see is a fall in the immunocompetent T cells, a reversal of the CD4 and the CD8 ratios, and hormonal antibody production will remain normal. Clinical features in Hodgkin's lymphomas is the age. It has a bimodal distribution. That means it occurs between the age group of 15 to 35, and when it stops at the age of 35 more or less, and then from 50 to above. So it's a bimodal pattern. Males are more effective vis-a-vis the females, except in nodular sclerosis. As mentioned previously, the females are more effective. It's a painless, mobile or movable, firm lymph adenopathy. Splenohepatomegaly is seen in 50% of the cases, and the constitutional symptoms are seen in 25 to 40% of the cases. Now, what are the constitutional symptoms? It will be weakness. The patient will come to you and complain of weakness, malaise, loss of appetite, feeling nausea, vomiting, and kind of generalized feeling of not being well. Now, how do you stage Hodgkin's lymphoma? It's done based on the histopathological examination, clinical features, and the extent of the spread. So there are 3 factors which come into play. Staging is done. Why is staging done? It is done for treatment, planning, and assess the prognosis. What are the treatment modalities? We use chemotherapy and radiation. Treatment sufficiently improves the staging and the histological time. 5-year survival rate is seen in stage 1 and stage 2A, 100%. Advanced stage 4 shows a 50% survival rate, 5-year survival rate. These are a few photomicrographs in which you can see a nodular growth pattern, polypoidal RS cells, Marked part is lymphocytes, bands of collagen, lacunar iris cells, nodular growth pattern with polypoidal iris cells as mentioned earlier. You see a Hodgkins cell, a depleted lymphoid cells, diffuse fibrosis, pleomorphic iris cells. You see histiocytes, proliferation of iris lymphocytes, that means you see large number of lymphocytes and relatively less number of iris cells. And a classical mixed stem cell. There is a specific classification that we refer to, and that is the Ann Amor staging classification of Hodgkin lymphoma, in which stage 1 is the involvement of a single lymph node region. With A or B. A or B is basically with constitutional symptoms or not. A is without constitutional symptoms and B is with constitutional symptoms. 1E is involvement of a single extra lymphocytic organ or cell. Stage 2 is involvement of 2 or more lymph node lesions on the same side of the diaphragm. Again A or B. 2E is with localized contiguous involvement of a extranodal organ or cell. Stage 3, again A or B, is involvement of the lymph node regions on both sides of the diaphragm. Stage 3E. Just a minute. There's been, Stage 3E with localized contiguous involvement of extranodal organs or site. Stage 3S with involvement of the spleen, and stage 3ES is both features of stage 3E and 3S. Stage 4 of course is multiple and disseminated involvement of one or more extra lymphatic organs or tissues with or without lymphatic involvement. Then the contrasting features of Hodgkin's lymphoma versus non-Hodgkin's is the cell derivation is in Hodgkin's is B cell, in non-Hodgkin's it's T cell, 90% B cell, 10% T cell, and nodular involvement localized. Vis-a-vis in NHL it's disseminated, extranodal spread is uncommon. In NHL it's common, bone marrow involvement is uncommon, in NHL it's common, constitutional symptoms is common, in Hodgkin's uncommon, in non-Hodgkin's, chromosomal defects is aneuploidy, and in Hodgkin's and translocations and deletions in non-Hodgkin's. Spillover is never seen in Hodgkin's, and in non-Hodgkin's may spread to the bloodstream. Overall prognosis is better in Hodgkin's vis-a-vis non-Hodgkin's. Thank you, that was all for this morning.